I'm going to kind of describe some OCT opportunities to address these problems that you're talking about, give you kind of show you some preliminary results and talk a little bit about what might be next. But to give a little background on who I am and what I do. So I'm over here at MGH, and in my group, we're looking at OCT as a tool. So we're mostly tool developers, and we're looking at how we can evolve OCT and improve it towards different applications, a broad set of different applications. And recently, probably over the last 5 or a little bit longer years, we have focused on intraoperative applications of OCT. OCT has traditionally been used as a diagnostic, and when you go intraoperative, there's certain technical requirements that get introduced that have been challenging traditionally for OCT, speed and depth range and field, and just the ability to kind of not be as finicky of an instrument has been a challenge for OCT. So we've been working to try to solve that. And in the context of that, I got linked up, and I don't even remember how, with AK and Bob and Frank talking about potential opportunities in this application space, and we had some great discussions and some great studies. So let's get started on those. So my learning objectives that I was told to put in, hopefully you will be able to understand some basic principles and capabilities of OCT. We can look at what's been done thus far in conduction tissue imaging, and then have a great discussion on what might be next and what would be the rationale for pursuing an OCT solution. Disclosures, I have some IP and licensing of OCT technology to various companies in a couple of different spaces, but nothing relevant in the cardiac surgery space. All right, so let's get started with a real high level, try to get everyone on a common ground here. So what is OCT? What is optical coherence tomography? So it's great that I can follow all these talks on confocal microscopy, fluorescence confocal, because at the high level, OCT is another way of doing that kind of three-dimensional optical imaging at fairly high resolutions, very similar to confocal. Like confocal, OCT scans an optical beam across the tissue. So you can just imagine over time, some beam getting rapidly scanned across and making measurements sequentially as it goes to accumulate information so that you can get either a 2D or a 3D image. The distinction of OCT relative to confocal is that the way that we measure the depth of a signal is not through defining a focal plane with a really highly focusing lens, as in confocal. And just to connect it to the last talk on light scattering spectroscopy, it's not via separating out our illumination and collection probes. OCT really works on the same principle as ultrasound or sonar. We measure how long it takes, the time of flight of light as it launches into the tissue, and then as it comes back, and we can measure that time of flight with very, very high precision so that we can tell whether light was scattered from a surface A or a surface B that's 10 microns lower than surface A. And from that, we construct an image. And what we measure with OCT fundamentally is the intrinsic scattering. So we're not using labels, we're not looking at fluorescence, we're not applying anything to see contrast. We see and we measure how strongly scattering the light is spatially resolved across the tissue, and that gives us an image, as I'll show you. So in schematic form, you can imagine a lens a distance away from the tissue launching light, and what OCT does is it's able to look at all these reflections and say, okay, I want to just look at the reflections that came with one particular time delay, which means they reflected from one particular location, and I'll attribute that to a particular pixel in my image, repeat that process across depth, scan the beam laterally, and I rebuild and reconstruct a scattering map of the sample that looks something like this. So high level, what are the key features of OCT, at least as relevant, I think, to this application? As I mentioned, it is label free. So we're just using the intrinsic scattering of the tissue, like light scattering spectroscopy. So it's very easy to bring it into the clinic. The regulatory burden is not drug-based. So it does typically need an IDE if there's a sterilization or an infection risk. But that's relatively straightforward and has been done in a number of different fields. Imaging depth is deeper because of, again, the mechanism of how we do depth sectioning in OCT. So it's about 1 to 2 millimeters in depth that we can see. The resolution, both lateral and axial, for an OCT image is a knob that we can turn, and it's always a balancing between different priorities in the system. but you can kind of set that knob typically between about 5 and 50 microns. 5 is maybe a little bit aggressive for most applications, but because of that, OCT is not a cellular imaging approach. It's not going to resolve cells or subcellular features. It's more microarchitectural. It's more looking at the organization of cells than cellular phenotypes and cellular architectures themselves. One thing that's I think unique to OCT is that you can image with a large standoff distance. So it doesn't require you to contact the OCT probe to the tissue. You can image, you can kind of almost think of it like a camera that's a few centimeters away from the tissue, and you launch light through the air into the tissue and collect what comes back again through that air media. So that makes it pretty easy to deploy in a lot of surgical settings. And we're even working on a project where we integrate the OCT instrument into the lighting that the surgeon wears on their head above their surgical loop, so that we're beaming the OCT signals from the surgeon's head directly into the field and then collecting them from the same location. So 30 or 40 centimeters away from the surgical field. So we can do we can entertain some deployment strategies in OCT that aren't traditionally accessible in optical imaging, or at least in depth sectioning optical imaging. And then we can image across large fields. So these are some nice attractive features for OCT that draw our group towards building it towards intraoperative applications. So returning to what an OCT image looks like, this is an image that I usually show because I think most people are familiar with the basic structure of skin. So this is an OCT image of human skin, and you can kind of relate this to what you know should be there. We have the surface up top. Above that is air or glass. This is actually imaged through a glass window. So that's that dark black line that you see there. And then the stratum corneum and the epidermis and dermis show up with a great deal of contrast in this image. And again, it's all based on just how intrinsically scattering the tissues are. So the darker the pixel here, the more scattering it is. The stratum corneum is a little bit more translucent. The epidermis is quite scattering, and the dermis has some heterogeneity in its scattering, so it comes through. OCT, as you may or may not know, it's very hard for me to judge, being an OCT person, how far into the how well understood the OCT penetration into clinical medicine is. But if you've ever had any more than a kind of a conventional eye exam at your optometrist, you've probably had an OCT image taken of your eye. It has been for about 20 years standard of care in ophthalmology for both posterior imaging of the retina and anterior imaging for pre-surgical guidance or cataract surgery planning or assessments. And the reason is it gives beautiful images of the retinal structure in a tissue that you just can't access otherwise easily, and you can't biopsy. So there's unique opportunity for optical microscopies like OCT to bring clinical value. So that's the biggest commercial market, clinical commercial market for OCT is in ophthalmology, pretty significant market. The other one I would mention that has developed and is strong and robust and stable is the use of OCT in interventional cardiology. So here it's used mostly in Japan, but somewhat in the US to understand the sort of the plaque structure and the health and the coronary artery disease status assessments. And it is sometimes used to monitor stent placements and to look at restenosis and response to stents. And it's pretty widely used in cardiovascular disease research as well. So the idea here is, of course, we can only image about 1 or 2 millimeters deep. So you build your OCT into a probe, a little optical probe that's shown on the left. Thread that into the coronary artery with a device that's shown in the middle here. This is an optical rotary junction, this silver box here that spins that catheter. So the imaging beam that side fires spins around, and then you do a blood flush to flush the blood out because it's difficult to see through blood. And you got a few seconds where you can image. And then you get a three-dimensional image like this. So this is what you pull out of it. And from this, you can see plaques, and you can measure wall thicknesses and calcium deposits and stent locations and restenosis and a number of different things. So these are the two areas where OCT has found the most utilization in clinical practice. Both of them are based on structural contrast measures in structural contrast, so looking at the scattering of light, and that's often enough. But I want to highlight two other mechanisms of contrast in OCT because I think at least one of them is I know, highly relevant for this application, and one would be interesting to put it on the table just in case somebody here sees opportunity there. But what I'm showing you right here is a cross-sectional image of a peripheral nerve. This is an image we took of an exposed peripheral nerve in a rat. We were doing some peripheral nerve studies. And so on the left side is muscle, this bulge in the middle is the nerve, and on the right side is muscle. And it looks pretty homogeneous. There's not a whole lot of contrast between muscle and nerve. Other than the surface variation, it's a little hard to see what's going on, and that's based on scattering properties. So a way that we address this when we need more contrast, and if we're lucky for the tissues that we're interested in, is we look not just at how the light scatters, how much it scatters, but we look at the effect that the tissue has on the polarization of the light. So that same data set is processed to look at polarization in this middle column here. And maybe I'll skip this plot of the data across the sphere, but just to suffice it to say that polarization is a more complex parameter than intensity. And so it takes a more complex mathematical framework to understand how the tissue is modulated in polarization. But we have tools to do that. And then from that, we can construct an image that is based on how the tissue modulates or rotates and in what way it rotates the light polarization. And so these are cross-sectional images showing that. And you can now see that these two muscles, the left and the right muscle, show up very differently because their fibers are oriented in different directions. And within the nerve, we can very clearly delineate the fascicle from the epineurium because they also modulate the polarization of light in very, very distinct ways. So it gives us this additional burst of intrinsic contrast for some tissues that can be quite useful. And then the final contrast mode I want to put on the table is vascular imaging by OCT. The basic idea here is very analogous to vascular imaging by ultrasound. We look at how stable an OCT signal is over time. And so via Doppler-like effects, we can detect where there is moving scatters, moving RBCs versus static tissue. This is an image, it was a little small, so I flipped it and made it bigger so you can see. This is an image again of peripheral nerve, just to keep it consistent, of a vascular map of angiogram of that peripheral nerve site. And the green vesicles are those that are lying within the fascicles. The white are those that are lying outside the fascicles. And this is in the context of a peripheral nerve injury, so you see a revascularization. So detailed vascular imaging is also in play for OCT, although it's a little bit trickier to pull off. So it kind of needs to be critical for it to be the right way to go. So let's return now to the topic at hand here, which is using this in the context of conduction tissue imaging and delineating conduction tissues in the heart. So the first question when we started talking with AK and Bob and Frank is, do we think that, or do we have evidence that OCT can provide contrast for conduction tissues? Because this really hasn't been significantly studied thus far. There was a paper in 2002 with very early OCT technology shown here that was a little bit hard. I think for me, it's hard to interpret what you see and to draw any conclusions from. This is structural OCT. In 2019, there's a paper where they looked again at structural OCT in porcine hearts, looking at the AV node. And what they are showing here, circled in yellow, are regions of hypoechoic or low scattering regions within the OCT image that correlate histologically to the AV node. It's encouraging, I would say, but it's obviously a pretty muted contrast here between what they've circled and the surrounding tissue. So scattering magnitude itself, I think, is maybe a challenge for reliable identification of conduction tissues. But when you look at the polarization signal, and this is work that we did with Abhijit and my postdoc at the time, set up a procedure where they brought over a swine heart, and did some OCT imaging with a benchtop instrument here. And I think it looks a lot better with the PS contrast. So this camera image in A is replicated in OCT in B, C, and D. B, C, and D are both projections of the OCT data. You can see this little wire here, this little loop that you can then make out in the OCT images for registration. B is the scattering image. So it's a projection of the scattering density. It doesn't have clear contrast. I'm going to just skip what image C is here because it's a little much to explain. But D is a map of what we derive in OCT for the orientation of effectively the muscle fibers. So different colors mean muscle fibers are oriented in a different angular direction. So you can start to see how OCT can pull out quite a bit of intrinsic contrast for different architectural features of the tissues. And you can see within this loop here, which was denoted as the AV node within here, you see a kind of a more muted appearance, and it does look different than surrounding tissues. But it is also very complex. So there's certainly reason to be, I think, encouraged by these results, but it I think warrants further exploration to understand exactly what the signals are that we're looking at. I can show it to you in a slightly different presentation here. These are similar data, or the same heart, but a different data set where we're just displaying it in a different way. And I would just want to highlight two of these OCT images, C and E here. Denoted in red here is what I believe was marked as the AV node. You can confirm that for me. Not a whole lot of contrast in this upper image, which is the structural OCT image, although you do see quite a bit of penetration depth, which is encouraging. But in the polarization image down here, you can see that region is characterized by a different texture in the coloration, which indicates that the organization of that tissue, it's less organized as a tissue than the tissues that are surrounding it, which are a more homogeneous color contrast, which I think is consistent with what you would expect for conduction tissues. So I think there's quite a bit of encouraging contrast that comes out of this, and it's I think one thing that is challenging in PSOCT imaging is that it's a very multidimensional data set that we're trying to reduce into an image and display it in a 2D image here. So it's three-dimensional spatially, which we always try to compress because it's very difficult to visualize in 3 dimensions. And then every point that we measure in a PS image is actually a 4-dimensional vector for the polarization state. So it's quite hard to know how to tailor an algorithm to extract that information. But I think this is, going back to some of the previous talks, this is really where machine learning can excel. And I think that the fact that we can see it and we can construct a tailored algorithm to show contrast suggests to me that when we unleash machine learning, if we can figure out how to train it appropriately on these multidimensional data sets, it would you'd have great results, great contrast for automated delineation of conduction tissues and normal hearts. To be proven, of course, but something that I'm quite optimistic on. So I think that's kind of where we're at. Like I said, it's very preliminary. We did that one study, but I think it was encouraging that OCT is a strong candidate for providing good contrast for conduction tissues. And then the second question, which I always like to think through and would love to hear more about from this panel, is can OCT meet the surgical requirements? Can it be deployed in a way that's consistent with the workflow of the surgery? Can it not get in the way? Cost was brought up in the last talk. Is it within the cost range of this application too? And so maybe just to prep that discussion, let me just give you a little bit for how OCT is often deployed. I mentioned that OCT can be done from a distance. It doesn't need contact. So that gives us a potential advantage where you can bring in a handheld probe and image large areas sort of at video rate at a distance from the tissue, whether it's a few millimeters or a few centimeters, that can all be set. And this is work from another OCT group, but just kind of showing the sophistication of the small handheld forward-looking OCT beam scanners that are being developed for other applications here, where they bring in very small optical fibers and MEMS scanners to do the beam scanning. And the whole thing can be packaged up into a really small package that looks, I think it's a little bit bigger than the Mauna Kea. This is 5.5 millimeter diameter, but it's not way off. And so it's certainly within reason to build very small handheld probes to bring into the surgical field. And then the other thing I just would note here is what we're doing in our lab is working towards really accelerating the speed and the flexibility of OCT so we can get video rate 4D imaging from which machine learning would then derive information and project that back to the surgeon. And these are just two examples of results that we've had on that path. And the left side is a view of an exposed nerve in a rat while it's being manipulated by forceps. So you can see that we're able to capture data over a large field at video rates. And then the right image is something we've just put together where we are doing retinal imaging in a human subject, again at video rate over 3 dimensions. So these are about 5 by 5 millimeter fields, retinal imaging, video rate imaging. So OCT's got a number of different ways in which it can be deployed, but I think the key is that it can be put into a probe, or it can be held back at a distance and image over a large field, and all of it can be done at very, very high speed. So it can be potentially very easy to integrate into the surgical procedure if we can figure out how to display that information back to the surgeon. So, like I said, OCT, I think it's a very intriguing approach for this application, but it's at the early stages of exploration. We need a lot more effort to try to understand what we see in OCT images in conduction tissues versus normal versus non-conduction tissues in the heart. But the evidence is that it can differentiate it based on PS, and that's not surprising given what we know PS techniques, polarization sensitive techniques measure and how conduction tissues are organized. Machine learning is likely going to be a necessary component in the future. I don't know that it needs to get addressed right away, but it's very complex multidimensional data that comes back, and something's going to have to simplify that and ideally just classify it like green, red. And machine learning seems like the best candidate for that. It's deployable in miniaturized probes, 2D imaging, just to give you a sense for where OCT is at in its maturity. 2D imaging, so meaning cross-sectional imaging at video rates, is very straightforward now with existing technologies. Video rate 3-dimensional imaging, as I showed you in the previous slide, is sort of on the verge, and it's coming over the horizon within the next few years. So that's certainly possible too. And love to talk more about what makes sense and what doesn't for this application in OCT. And then finally, just call out my postdoc Mohsen and Abhijit for doing those imaging studies a couple of years ago, and Stephanie Nam, my group, did all of the PSOCT signal and image processing that generates those images, and highlight that we do have a P41, an NIH-funded P41 Center for OCT Research and Translation at this website. So this is a great way for new potential opportunities for OCT to get explored. We're always happy to hear people reach out and suggest a way in which OCT might help their research and start that discussion with them.